Question 1. A 35-year-old construction worker sustained a traumatic injury to the volar aspect of his left wrist, resulting in a complete transection of the median nerve at the level of the carpal tunnel. Which functional deficit would be most indicative of the severity of this injury postoperatively, after initial healing but prior to significant reinnervation? A. Inability to make a full fist. B. Loss of sensation over the ulnar half of the ring finger. C. Weakness in wrist extension. D. Inability to oppose the thumb to the small finger. Answer: D. Inability to oppose the thumb to the small finger. This question tests understanding of median nerve anatomy and its functional impact when injured at the wrist. The keyword complete transection at the carpal tunnel is crucial, indicating a low median nerve injury affecting the thenar muscles innervated by the recurrent motor branch of the median nerve. Loss of thumb opposition, specifically affecting the opponent's pollicis muscle, is the classic and most functionally debilitating motor deficit after a complete low median nerve injury. While general grip may be affected, and sensation would be lost over the radial 3.5 digits, not the ulnar half of the ring finger, the inability to oppose the thumb directly impacts fine motor skills and grasping, which are essential for hand function. Always remember that for median nerve injuries at the wrist, think ape hand deformity and the profound loss of thumb opposition. Question 2. A patient presents with severe rheumatoid arthritis, exhibiting a swan neck deformity with a flexible PIP joint hyperextension and a fixed dip joint flexion. What is the most appropriate splinting intervention for this specific deformity? A. A volar PIP extension block splint. B. A dorsal PIP extension block splint. C. A digital gutter splint in slight PIP flexion. D. A figure of 8 splint or a dorsal ring splint. Answer: D. A figure of 8 splint or a dorsal ring splint. This question assesses knowledge of rheumatoid arthritis deformities and appropriate orthotic management. The keywords swan neck deformity and flexible PIP joint hyperextension, fixed dip joint flexion describe the characteristic presentation that needs to be addressed. A figure of 8 splint or a dorsal ring splint is the most appropriate intervention because it is designed to block PIP hyperextension while allowing full PIP flexion, thereby preventing the deformity from worsening and reducing stress on the affected joints. This splint effectively manages the primary issue of PIP hyperextension without restricting the ability to bend the finger for functional tasks. For swan neck deformities, remember the goal is to prevent hyperextension at the PIP joint while preserving other movements, and ring splints are often the go-to solution. Question 3. A patient presents 6 weeks post-surgical repair of a Zone 2 flexor digitorum profundus, FDP, laceration. Which of the following is the most critical complication to monitor for at this stage of rehabilitation? A. Extensor lag at the MCP joint. B. Fixed wrist flexion contracture. C. Adhesions leading to limited active flexion. D. Sensory loss in the digit. Answer: C. Adhesions leading to limited active flexion. This question focuses on critical complications following flexor tendon repairs, specifically in Zone 2, which is known as no man's land due to the high incidence of adhesions. The keywords Zone 2 flexor digitorum profundus laceration and 6 weeks post-surgical repair are key indicators. At this stage, the tendon healing is progressing, and the risk of developing dense adhesions that tether the tendon and restrict glide is very high. Adhesions directly lead to limited active flexion despite passive range of motion, significantly impacting functional outcomes. While other issues can occur, adhesions are the most common and challenging complication to manage in this specific zone and timeframe. Always keep in mind that adhesions are the arch nemesis of flexor tendon healing, especially in Zone 2. Question 4. A hand therapist is considering the use of therapeutic ultrasound for a patient with chronic lateral epicondylitis. Which of the following conditions would be an absolute contraindication for applying ultrasound to the affected area? A. Presence of a metal plate and screws from a previous fracture fixation. B. Patient history of mild hypertension. C. Active inflammation and acute pain. D. Sensory deficits in the forearm. Answer: A. Presence of a metal plate and screws from a previous fracture fixation. This question tests knowledge of absolute contraindications for therapeutic ultrasound. The keyword absolute contraindication implies a condition where ultrasound should never be used due to significant risk. While metal implants are generally safe with pulsed ultrasound, the presence of a metal plate and screws can pose a risk for continuous ultrasound due to heat absorption by the metal, potentially causing tissue damage or thermal burns. This is a common and critical safety consideration. Active inflammation and acute pain are often indications for pulsed ultrasound, not contraindications, and hypertension or sensory deficits are typically relative contraindications or require caution, but not absolute avoidance. Always prioritize patient safety. Metal implants, especially near superficial bone, are a red flag for continuous ultrasound. Question 5. A patient is referred for rehabilitation following a central slip laceration repair of the extensor digitorum communis at the PIP joint, resulting in a boutonniere deformity. What is the primary goal of splinting in the early stages of recovery? A. To prevent dip joint hyperextension. B. To promote PIP joint flexion. C. To maintain PIP joint extension while allowing dip joint flexion. D. To immobilize the entire finger in extension. Answer: C. To maintain PIP joint extension while allowing dip joint flexion. This question focuses on the specific splinting principles for a boutonniere deformity following a central slip laceration repair. The keywords central slip laceration repair and boutonniere deformity highlight the critical need to protect the healing central slip and prevent the characteristic PIP flexion and dip hyperextension. The primary goal of splinting in this scenario is to maintain the PIP joint in full extension to allow the central slip to heal in a shortened position, while simultaneously permitting full active and passive dip joint flexion. This allows the lateral bands to glide volarly and stretch, which prevents their shortening and helps maintain the balance of the extensor mechanism. Remember, for a boutonniere injury, the PIP joint must be extended, but the dip joint must be free to move. Question 6. A 48-year-old patient reports severe burning pain, allodynia, pseudomotor changes, and trophic changes in her hand following a distal radius fracture 3 months prior. Her symptoms are out of proportion to the initial injury. Which of the following conditions is most likely indicated by these symptoms? A. Carpal tunnel syndrome. B. Complex regional pain syndrome, CRPS. C. Thoracic outlet syndrome. D. Ulnar nerve entrapment. Answer: B. Complex regional pain syndrome, CRPS. This question describes a classic presentation of complex regional pain syndrome, CRPS. The keywords severe burning pain, allodynia, pain from a non-painful stimulus, pseudomotor changes, sweating abnormalities, trophic changes, skin/nail/hair changes, and pain out of proportion to injury are hallmark diagnostic criteria for CRPS, particularly after trauma like a fracture. Carpal tunnel syndrome primarily presents with numbness/tingling and weakness in the median nerve distribution, while thoracic outlet syndrome and ulnar nerve entrapment have distinct pain and sensory patterns. When you see a constellation of disproportionate pain, autonomic, motor, and trophic changes after an injury, immediately think CRPS. Question 7. A patient sustained a gamekeeper's, skier's, thumb injury. Which of the following ligaments is primarily affected in this condition? A. Radial collateral ligament of the thumb MP joint. B. Volar plate of the thumb MP joint. C. Ulnar collateral ligament of the thumb MP joint. D. Transverse carpal ligament. Answer: C. Ulnar collateral ligament of the thumb MP joint. This question tests specific anatomical knowledge related to common hand injuries. Gamekeepers, skiers, thumb is the classic term for an injury to the ulnar collateral ligament, UCL, of the metacarpophalangeal, MP, joint of the thumb. This ligament is crucial for stabilizing the thumb on the radial side, preventing excessive abduction and valgus stress. Injury often occurs from a forceful abduction and hyperextension of the thumb. The radial collateral ligament is on the opposite side, the volar plate prevents hyperextension, and the transverse carpal ligament is unrelated to this specific thumb injury. Remember that gamekeeper's thumb always means the UCL of the thumb MP joint, which is vital for pinch strength. Question 8. A hand therapist is evaluating a patient with a chronic wrist injury and wants to use a region-specific outcome measure that is reliable and valid for upper extremity function. Which of the following is the most appropriate choice? A. Functional Independence Measure, FIM. B. Grip Strength Dynamometry. C. Disabilities of the Arm, Shoulder and Hand, Questionnaire. D. Visual Analog Scale, VAS. Answer: C. Disabilities of the Arm, Shoulder and Hand, Questionnaire. This question focuses on selecting the most appropriate region-specific outcome measure for upper extremity function. The keywords chronic wrist injury, region-specific, and upper extremity function point directly to the questionnaire. The is a widely used, validated, and reliable patient-reported outcome measure specifically designed to assess physical function and symptoms in people with musculoskeletal disorders of the entire upper extremity. While grip strength and VAS are important for specific aspects, strength, pain, and FIM is a broader measure of independence, only the captures the comprehensive functional impact across the arm, shoulder, and hand. For comprehensive upper extremity assessment, remember the or its shorter version, the quick dash. Question 9. A patient with advanced rheumatoid arthritis presents with significant ulnar drift at the MCP joints. What is the primary mechanical goal of an orthosis designed to manage this deformity? A. To prevent dip joint hyperextension. B. To increase wrist extension. C. To radially align the MCP joints and prevent further ulnar deviation. D. To block MP joint flexion. Answer: C. To radially align the MCP joints and prevent further ulnar deviation. This question tests the understanding of orthotic principles for specific deformities in rheumatoid arthritis. The keywords ulnar drift at the MCP joints indicate the classic deviation of the fingers toward the ulnar side, which is a common and functionally limiting deformity in RA. The primary mechanical goal of an orthosis, such as a resting hand splint or a functional splint with a dynamic pull, is to counteract this ulnar deviation by applying a corrective radial force to the MCP joints. This helps to realign the joints, reduce stress on the supporting structures, and maintain functional positioning. The splint does not aim to affect dip hyperextension, wrist extension, or block MP flexion as a primary goal for ulnar drift. Always remember that for ulnar drift, the main purpose of splinting is to gently push the fingers back towards radial alignment. Question 10. A hand therapist is managing a patient with a full-thickness burn to the dorsum of the hand. Which of the following is the most appropriate initial dressing choice to promote autolytic debridement and maintain a moist wound environment? A. Dry gauze. B. Hydrocolloid. C. Alginate. D. Silver sulfadiazine cream. Answer: B. Hydrocolloid. This question assesses knowledge of appropriate wound dressings for full-thickness burns, specifically focusing on autolytic debridement and maintaining moisture. The keywords full-thickness burn, autolytic debridement, and moist wound environment are crucial. Hydrocolloid dressings are excellent for maintaining a moist wound environment, which facilitates the body's natural autolytic debridement processes by allowing enzymes to break down necrotic tissue. Dry gauze would promote a dry environment. Alginate is typically for highly exudative wounds, and silver sulfadiazine is an antimicrobial cream, not primarily for autolytic debridement. When the goal is to gently debride and keep a wound moist, think hydrocolloids as a go-to option. Question 11. A patient presents with paresthesias in the long and ring fingers, along with weakness in intrinsic muscles of the hand, particularly the interossei. Which special test would most specifically help confirm a diagnosis of cubital tunnel syndrome? A. Phelan's test. B. Finkelstein's test. C. Elbow flexion test. D. Tinel's sign at the wrist. Answer: C. Elbow flexion test. This question tests knowledge of specific diagnostic tests for nerve entrapments. The symptoms, paresthesias in the long and ring fingers and weakness in intrinsic muscles, particularly interossei, are classic indicators of ulnar nerve involvement. The keyword cubital tunnel syndrome points to entrapment at the elbow. The elbow flexion test, which involves holding the elbow in maximal flexion for 30 to 60 seconds, compresses the ulnar nerve in the cubital tunnel and is designed to reproduce symptoms, thus specifically confirming cubital tunnel syndrome. Phelan's test is for carpal tunnel, median nerve, Finkelstein's for de Quervain's tenosynovitis, and Tinel's at the wrist would be for carpal tunnel or Guyon's canal, not specifically cubital tunnel. For cubital tunnel, remember the elbow flexion test aggravates the ulnar nerve at its entrapment site. Question 12. A 6-month-old infant is diagnosed with an Erb's palsy, C5-C6 brachial plexus injury. Which characteristic arm posture would a hand therapist most likely observe in this child? A. Shoulder adducted, internally rotated, elbow extended, forearm pronated. B. Shoulder abducted, externally rotated, elbow flexed, forearm supinated. C. Shoulder flexed, elbow extended, wrist pronated. D. Shoulder abducted, elbow extended, wrist flexed. Answer: A. Shoulder adducted, internally rotated, elbow extended, forearm pronated. This question assesses understanding of the classic presentation of Erb's palsy, a common brachial plexus birth injury. Erb's palsy typically involves injury to the upper trunk, C5-C6, of the brachial plexus, affecting muscles like the deltoid, supraspinatus, infraspinatus, biceps, and brachialis. The characteristic posture resulting from weakness or paralysis of these muscles is often described as the waiter's tip position. The shoulder is adducted and internally rotated, the elbow is extended, and the forearm is pronated. This posture is a direct result of the affected muscle groups. For Erb's palsy, visualize the waiter's tip posture: shoulder down, arm straight, palm backward. Question 13. A patient presents with acute, significant edema in the hand following a crush injury. The therapist decides to use manual edema mobilization, MEM, techniques. Which of the following is the most appropriate initial technique to apply in this acute stage? A. Retrograde massage with firm pressure. B. Joint mobilization to improve range of motion. C. Gentle proximal clearing strokes and light compression. D. Aggressive active range of motion exercises. Answer: C. Gentle proximal clearing strokes and light compression. This question focuses on appropriate edema management techniques in the acute phase. The keywords acute, significant edema, and crush injury indicate a need for gentle, non-aggressive techniques to avoid further tissue damage or inflammation. In MEM, the initial approach involves gentle proximal clearing strokes to open lymphatic pathways and prepare the more distal areas for fluid movement, followed by light compression to encourage fluid reabsorption and prevent accumulation. Retrograde massage with firm pressure is contraindicated in acute edema due to the risk of tissue damage. Joint mobilization is not the primary edema technique, and aggressive active range of motion might increase inflammation. For acute edema, always start proximally and use light, gentle strokes to clear the path. Question 14. A patient undergoes a transradial, below elbow, amputation. During the immediate postoperative phase, what is the primary goal of rehabilitation? A. To immediately fit a definitive prosthetic limb. B. To initiate resistive strengthening exercises for the residual limb. C. To promote wound healing, control edema, and shape the residual limb. D. To focus solely on psychosocial adjustment to limb loss. Answer: C. To promote wound healing, control edema, and shape the residual limb. This question addresses the immediate postoperative goals following an amputation. The keywords transradial amputation and immediate postoperative phase are crucial. In this early stage, the primary focus is on ensuring proper healing of the surgical site, managing post-surgical edema to prevent complications and prepare the limb for prosthetic fitting, and shaping the residual limb into an optimal conical form for prosthesis suspension. Immediate definitive prosthetic fitting is typically not feasible due to swelling and wound healing needs, and resistive exercises are premature. While psychosocial adjustment is important, it's not the primary physical goal in the immediate post-op phase. Think of the immediate post-op phase as laying the groundwork for a successful prosthetic fit, heal, shrink, and shape. Question 15. A patient presents with a large, hypertrophic burn scar on the dorsal hand, limiting full finger extension. Which of the following interventions would be most effective in remodeling the scar tissue and improving range of motion? A. Application of heat modalities only. B. Static progressive splinting combined with scar massage and silicone gel sheeting. C. Aggressive passive stretching immediately. D. Short-wave diathermy. Answer: B. Static progressive splinting combined with scar massage and silicone gel sheeting. This question tests comprehensive knowledge of burn scar management and its impact on function. The keywords hypertrophic burn scar, limiting full finger extension, and remodeling the scar tissue indicate the need for interventions that apply prolonged stretch and modulate collagen synthesis. Static progressive splinting provides a sustained, gentle stretch to lengthen contractured tissues, which is highly effective for improving range of motion. Combining this with scar massage helps to soften the scar tissue and improve its pliability, while silicone gel sheeting is known to reduce scar hypertrophy and improve scar maturation. Heat modalities alone or aggressive stretching are insufficient or potentially harmful, and short-wave diathermy is not a primary scar remodeling intervention. For stubborn hypertrophic scars, remember the triad: prolonged stretch, splinting, manual mobilization, massage, and scar maturation, silicone. Question 16. A patient with a crush injury to the forearm presents with increasing pain disproportionate to the injury, pallor, paresthesia, pulselessness, and paralysis. Which of the following conditions is most likely indicated, requiring urgent medical intervention? A. Compartment syndrome. B. Peripheral neuropathy. C. Deep vein thrombosis. D. Cellulitis. Answer: A. Compartment syndrome. This question describes the classic 5 Ps: pain, pallor, paresthesia, pulselessness, paralysis, which are hallmark signs of compartment syndrome. The keyword crush injury significantly increases the risk for this condition, where increased pressure within a confined facial compartment compromises circulation and nerve function. Compartment syndrome is a medical emergency requiring immediate surgical intervention, fasciotomy, to prevent irreversible muscle and nerve damage. Peripheral neuropathy is a chronic nerve condition, deep vein thrombosis is a blood clot, and cellulitis is a bacterial infection of the skin, none of which present with this specific combination of rapidly progressive and severe symptoms. When you see the 5 Ps after trauma, immediately recognize the urgent need to address compartment syndrome. Question 17. A certified hand therapist is approached by a colleague to provide expert witness testimony in a complex medical malpractice case. The therapist has no prior experience with expert testimony but believes they have relevant clinical knowledge. According to ethical guidelines, what is the most appropriate initial action for the therapist to take? A. Accept the request immediately, as it offers a new learning opportunity. B. Decline the request due to lack of specific experience in legal proceedings. C. Consult with an experienced expert witness and review professional guidelines before making a decision. D. Provide testimony based solely on their clinical opinion without further preparation. Answer: C. Consult with an experienced expert witness and review professional guidelines before making a decision. This question tests ethical considerations related to professional competence and integrity. While the therapist possesses relevant clinical knowledge, the keywords "no prior experience with expert testimony" and "complex medical malpractice case" indicate a need for caution and due diligence. The most appropriate ethical action is to consult with an experienced expert witness and review professional guidelines, such as those from the AOTA or HTCC, to understand the responsibilities, expectations, and potential pitfalls of providing expert testimony. This ensures the therapist's competency in the legal arena and upholds professional standards, rather than accepting prematurely or declining without proper investigation. For any new professional role or challenge, always prioritize seeking guidance and reviewing guidelines to ensure competence and ethical practice. Question 18. A patient has a dorsal wrist ganglion cyst causing localized pain and some wrist extension limitation. After a period of non-operative management with conservative measures, the patient requests further options. Which of the following is considered the definitive treatment for a symptomatic ganglion cyst? A. Aspiration and steroid injection. B. Repeated splinting for immobilization. C. Surgical excision. D. Oral anti-inflammatory medication. Answer: C. Surgical excision. This question focuses on the definitive treatment for a symptomatic ganglion cyst. While conservative measures like splinting and anti-inflammatories, or aspiration with steroid injection, can provide temporary relief, they have high recurrence rates. The keyword definitive treatment implies a solution that aims for a permanent resolution. Surgical excision is considered the definitive treatment for ganglion cysts, especially when they are symptomatic and resistant to conservative measures, as it removes the cyst and its stalk, significantly reducing the chance of recurrence. Remember that aspiration is often a first-line intervention for symptoms, but surgical excision is the most effective long-term solution for symptomatic, persistent ganglion cysts. Question 19. A data entry clerk experiences chronic pain and tingling in their wrist and fingers, diagnosed as work-related cumulative trauma disorder, CTD. Which ergonomic intervention would be most beneficial in preventing recurrence of symptoms? A. Increasing typing speed to complete tasks faster. B. Using a wrist rest exclusively. C. Adjusting monitor height to eye level. D. Implementing regular microbreaks and varying tasks. Answer: D. Implementing regular microbreaks and varying tasks. This question addresses the prevention of cumulative trauma disorders, CTDs, in a work setting. The keywords chronic pain and tingling, work-related cumulative trauma disorder, and preventing recurrence highlight the need for ergonomic strategies that reduce repetitive strain. Implementing regular microbreaks, short pauses to stretch and rest, and varying tasks, alternating between different movements, are highly effective in breaking up repetitive cycles, reducing static postures, and allowing tissues to recover, thus preventing the accumulation of microscopic damage that leads to CTDs. While other options like monitor height are important for posture, and a wrist rest can be helpful but should not be used exclusively, microbreaks and task variation directly target the root cause of repetitive strain. For repetitive strain injuries, remember that breaking up the repetition with breaks and task variation is key. Question 20. A patient is 3 days postoperative for a metacarpophalangeal (MCP) joint arthroplasty due to severe osteoarthritis. What is the primary goal of early rehabilitation for this patient? A. Aggressive strengthening exercises for grip. B. Immediate initiation of passive range of motion with full resistance. C. Protecting the implant while initiating controlled active and passive range of motion. D. Complete immobilization for 6 weeks to ensure bone healing. Answer: C. Protecting the implant while initiating controlled active and passive range of motion. This question focuses on early postoperative rehabilitation principles following joint arthroplasty. The keywords 3 days postoperative and MCP joint arthroplasty indicate a very early, delicate phase of recovery where the primary concern is protecting the newly implanted joint. The goal is to initiate controlled active and passive range of motion exercises gently, to prevent stiffness and promote mobility while ensuring the implant is not stressed or dislocated. Aggressive strengthening, immediate full resistance, or complete long-term immobilization would be detrimental, risking implant failure or severe stiffness. For joint arthroplasty, always prioritize protecting the new joint while gently promoting early, controlled movement. Question 21. A patient with a high median nerve injury, proximal to the elbow, would present with weakness in which of the following muscles that would not be affected by a low median nerve injury at the wrist? A. Opponens pollicis. B. Flexor digitorum profundus to the index finger. C. Lumbricals to the index and middle fingers. D. Abductor pollicis brevis. Answer: B. Flexor digitorum profundus to the index finger. This question tests the differential diagnosis between high and low median nerve injuries based on muscle innervation. The key distinction is that a high median nerve injury affects muscles innervated by the median nerve before it enters the carpal tunnel, including those in the forearm, whereas a low median nerve injury at the wrist primarily affects the recurrent motor branch to the thenar muscles and the digital nerves. The flexor digitorum profundus to the index and middle fingers, along with flexor pollicis longus and pronator quadratus, is innervated by the anterior interosseous nerve, AIN, which branches off the median nerve in the forearm, making its weakness indicative of a high injury. The other options are thenar muscles or lumbricals, which are affected in low median nerve injuries. For nerve injuries, tracing the nerve's course and its proximal versus distal innervation is crucial for accurate diagnosis. Question 22. A hand therapist is reviewing research articles to inform clinical practice. An article describes a single patient's unique and successful recovery after a rare hand surgery. This type of article represents which level of evidence? A. Level 1, randomized controlled trial. B. Level 2, cohort study. C. Level 3, case control study. D. Level V, expert opinion/case report. Answer: D. Level V, expert opinion/case report. This question assesses knowledge of the hierarchy of evidence in research. The keywords single patient's unique and successful recovery and rare hand surgery directly describe a case report or case study. Case reports are considered the lowest level of evidence, level V, in the evidence-based practice hierarchy because they describe the experience of a single patient, which limits generalizability and has a high risk of bias. While valuable for hypothesis generation or describing rare occurrences, they do not provide strong evidence for intervention effectiveness compared to higher-level studies like randomized controlled trials, level 1, or cohort studies, level 2. When assessing evidence, remember that individual case reports, while interesting, are the weakest form of evidence. Question 23. A patient has undergone a traumatic amputation of the small finger at the level of the proximal phalanx. In the early rehabilitation phase, what is the primary functional focus for the remaining hand? A. Maximizing grip strength of the amputated digit. B. Maintaining full range of motion of the adjacent ring finger and minimizing scar sensitivity. C. Preparing for prosthetic fitting of the small finger. D. Desensitizing the stump for immediate weight-bearing activities. Answer: B. Maintaining full range of motion of the adjacent ring finger and minimizing scar sensitivity. This question targets the functional priorities after a digital amputation. The keywords traumatic amputation of the small finger at the proximal phalanx imply the loss of a digit, but the emphasis shifts to the function of the remaining hand. The primary functional focus is to ensure the health and optimal function of the adjacent digits, particularly the ring finger, which is now the ulnar border of the hand. This includes maintaining its full range of motion to prevent stiffness and contractures, and managing scar sensitivity, neuroma, hypersensitivity, at the stump and around the surgical site to prevent compensatory movements and allow for comfortable use of the hand. Prosthetic fitting for a single digit is less common and not the immediate primary goal for most patients, and maximizing grip strength of a non-existent digit is irrelevant. For digital amputations, always focus on optimizing the function and sensation of the remaining digits and the amputation site. Question 24. A patient with persistent cubital tunnel syndrome reports paresthesias and weakness despite conservative management. A key component of their daily routine involves prolonged elbow flexion. Which intervention would be most beneficial for continued conservative management? A. Custom elbow extension orthosis for night use. B. Aggressive stretching of the elbow flexors. C. Resistive exercises for wrist extensors. D. Heat application to the cubital tunnel. Answer: A. Custom elbow extension orthosis for night use. This question focuses on continued conservative management for cubital tunnel syndrome, particularly when prolonged elbow flexion exacerbates symptoms. The keywords persistent cubital tunnel syndrome, prolonged elbow flexion, and most beneficial indicate the need for an intervention that reduces sustained ulnar nerve compression at the elbow. A custom elbow extension orthosis, or static elbow splint, worn at night is highly beneficial because it prevents sustained elbow flexion during sleep, thereby reducing tension and compression on the ulnar nerve. Aggressive stretching or heat application might irritate the nerve, and resistive wrist extensor exercises are not directly relevant to the primary nerve compression. For cubital tunnel, remember to avoid sustained elbow flexion, especially at night, to reduce nerve tension. Question 25. A patient presents with a chronic boutonniere deformity, characterized by fixed PIP flexion and dip hyperextension. Which orthotic approach would be most effective in addressing this fixed deformity? A. A dynamic PIP extension assist splint. B. A static progressive PIP extension splint. C. A dorsal block splint at the PIP joint. D. A resting hand orthosis in neutral. Answer: B. A static progressive PIP extension splint. This question differentiates between managing acute boutonniere and chronic, fixed deformities. The keywords chronic boutonniere deformity and fixed PIP flexion are critical. For a fixed deformity, a static progressive splint is the most effective orthotic approach. This type of splint applies a constant, low-load, prolonged stretch to the stiff PIP joint, gradually increasing the extension force over time to lengthen the contractured tissues and correct the flexion deformity. A dynamic splint may not provide sufficient force for a fixed contracture, a dorsal block splint is for acute protection, and a resting hand orthosis is too general. When faced with a fixed joint contracture, Think static progressive splinting for sustained, gentle force. Question 26. A patient has undergone a nerve graft repair of the median nerve at the forearm level. Postoperatively, which of the following is the most critical consideration for early rehabilitation in the initial protective phase? A. Immediate sensory re-education using discriminative sensory tasks. B. Aggressive range of motion to prevent joint stiffness. C. Protection of the nerve repair site from tension or compression. D. High-resistance strengthening of the affected muscles. Answer: C. Protection of the nerve repair site from tension or compression. This question addresses the critical early postoperative considerations following a nerve graft repair. The keywords nerve graft repair, median nerve at the forearm, and initial protective phase emphasize the fragility of the healing nerve. The most critical consideration is absolute protection of the nerve repair site from any tension, stretch, or compression that could jeopardize the integrity of the graft and the delicate regenerating axons. This typically involves immobilization in a position that reduces tension on the nerve, e.g., elbow flexion, wrist flexion. Immediate sensory re-education or aggressive range of motion and strengthening are contraindicated and could disrupt the repair or nascent axonal growth. For nerve repairs, remember that protection is paramount in the early phases to allow for successful axonal regeneration. Question 27. A 40-year-old female presents with pain along the radial aspect of her wrist, exacerbated by gripping and lifting. She has a positive Finkelstein's test. Which of the following tendons are most likely inflamed in this condition? A. Flexor carpi radialis and palmaris longus. B. Abductor pollicis longus and extensor pollicis brevis. C. Extensor carpi radialis brevis and longus. D. Extensor pollicis longus and extensor indicis proprius. Answer: B. Abductor pollicis longus and extensor pollicis brevis. This question describes the classic presentation and diagnostic test for de Quervain's tenosynovitis. The keywords pain along the radial aspect of her wrist, exacerbated by gripping and lifting, and positive Finkelstein's test are direct indicators of this condition. De Quervain's tenosynovitis involves inflammation of the tendons of the first dorsal compartment of the wrist, which houses the abductor pollicis longus, APL, and extensor pollicis brevis, EPB, muscles. These tendons are responsible for thumb abduction and extension, and they are typically irritated as they pass through their common fibrous sheath. For radial wrist pain with a positive Finkelstein's, always think APL and EPB within the first dorsal compartment. Question 28. A patient sustains a mallet finger injury, resulting in an extensor lag at the dip joint. What is the most crucial splinting principle for successful non-operative management of this injury? A. Maintaining the dip joint in slight flexion to promote comfort. B. Immobilizing the dip joint in full extension or slight hyperextension continuously for 6 to 8 weeks. C. Allowing full active dip joint flexion while blocking hyperextension. D. Immobilizing the PIP joint to protect the extensor mechanism. Answer: B. Immobilizing the dip joint in full extension or slight hyperextension continuously for 6 to 8 weeks. This question focuses on the essential splinting protocol for a mallet finger injury. The keywords mallet finger injury and extensor lag at the dip joint indicate a disruption of the terminal extensor tendon, which requires a specific splinting strategy. The most crucial principle for non-operative management is continuous immobilization of the distal interphalangeal, DIP, joint in full extension or slight hyperextension for a prolonged period, typically 6 to 8 weeks. This allows the ruptured or avulsed extensor tendon to heal in a shortened position without tension. Any flexion, even brief, can disrupt the healing process. While other joints should remain free for movement, the dip joint must be kept perfectly straight. For mallet finger, remember rigid, continuous dip extension, no peaking or bending. Question 29. A patient is 2 weeks post-operative for a fasciectomy for Dupuytren's contracture of the ring finger. What is the most critical aspect of early post-operative rehabilitation to prevent recurrence and maximize functional range of motion? A. Immediate full return to unrestricted heavy gripping. B. Aggressive passive stretching of the fingers into extension. C. Wound care, edema control, and continuous gentle extension splinting. D. Complete immobilization of the hand for 4 weeks. Answer: C. Wound care, edema control, and continuous gentle extension splinting. This question addresses crucial early postoperative care following a fasciectomy for Dupuytren's contracture. The keywords 2 weeks postoperative, fasciectomy for Dupuytren's contracture, and most critical highlight the need for interventions that manage the surgical site, reduce swelling, and prevent recontracture. Post-fasciectomy, aggressive passive stretching or immediate heavy gripping are detrimental and can cause re-rupture or hematoma. Complete immobilization would lead to stiffness. The most critical approach involves meticulous wound care, rigorous edema control, often with compression, and continuous, gentle extension splinting, often custom fabricated, to maintain the newly gained extension and prevent the fibrous bands from shortening again. For Dupuytren's fasciectomy, always prioritize meticulous wound management, edema control, and maintaining extension with splinting. Question 30. A patient sustained a flexor digitorum profundus, FDP, laceration in zone I and underwent surgical repair. According to commonly accepted protocols, what is the primary goal of initial controlled active motion, CAM, or early passive motion, EPM, protocols? A. To prevent rupture of the repair site. B. To promote tendon gliding and prevent adhesion formation. C. To immediately restore full grip strength. D. To achieve maximum passive range of motion without active participation. Answer: B. To promote tendon gliding and prevent adhesion formation. This question focuses on the primary goal of early motion protocols for flexor tendon repairs. The keywords FDP laceration in zone I, surgical repair, and initial controlled active motion, CAM, or early passive motion, EPM, are critical. The primary goal of these carefully designed early motion protocols is to promote tendon excursion, gliding, within the tendon sheath and prevent the formation of dense adhesions between the healing tendon and surrounding tissues. While preventing rupture is a consideration, and restoring grip strength is an eventual goal, facilitating tendon glide is the immediate and crucial aim that allows for functional movement post-healing. Achieving maximum passive range of motion is part of it, but the underlying reason for controlled motion is to prevent the tendon from sticking. For flexor tendon protocols, always remember the main enemy, adhesions, and early motion is the best weapon against them.